membership organization that is an affiliate of the Medical Society of Sedgwick County. Our mission is to assist employers with lowering their healthcare costs through education and benefit design. So if you are interested, if you're not a member and interested in becoming a member, I encourage you to check out our website. I first want to thank our sponsors for 2020. They sponsor all of our conferences and trainings, and those include Blue Cross Blue Shield of Kansas, Entrust, United Healthcare, and Child Start. The first thing that I want to do is we're going to be talking about telemental health today specifically. And I think I know we've been hearing a whole lot more about telehealth since the pandemic has started, and we've seen a real increase in that, but we're also seeing an increase in telemental health. And our speakers today have been doing that for a long time. And so I'm really excited to hear their presentations. The Kansas Business Group on Health is really beginning to focus more and more on behavioral health and now tele-behavioral health. And you will be hearing more about that as time goes on. I'll share with you a little bit about a project that we're working on right now. That's a project through the National Alliance of Healthcare Purchaser Coalitions. And speaking of the National Alliance of Healthcare Purchaser Coalitions, which is a coalition of coalitions and of which we are a member, and I want to talk a little bit about a survey that they did in collaboration with Lyra Health. And the goal of the survey was really to survey U.S. workers throughout the country on about how they're feeling during this time, the public health crisis, the economic downturn, the national conversation on health equity, systemic racism, and how that's affecting their mental health. They wanted to understand the symptoms that people are experiencing, how they're coping, and what support they're getting from their employer. They had a 19-question survey, and some of the questions that included on there were included what they would say about the events over the last few months and how those have interfered with their ability to work. If they are feeling like their employer has supported their mental health or offering enough resources during this time, and if they're considering a career change because of stress over the last few months. I went over what the National Alliance of Healthcare Purchaser Coalitions, who they are, but also Lyra Health, just a word about them. We're not endorsing them, but they are a virtual mental health platform that provides personalized care, a match with a provider that is specific to an employer's needs. And in addition to the treatment that they offer, they provide motivation and support through the treatment journey. This survey, next slide, sorry, Matt. Thanks. The survey included, I'm not sure how many people they sent the survey to, but there were 1,265 respondents, and they completed this survey between June the 25th and 30th of this year, so it's fresh. It's less than 6 weeks old. They surveyed United States residents, obviously people that are working at different companies that are 18 years and older and that were employed full-time. And on this slide, you can see the age breakdown in the middle, the blue graph. The highest number of respondents were between the ages of 35 and 44. In the graph below that, you can see this identifies the company size, and the majority of respondents work for companies that have over 1,000 employees. And on the right side of this slide, you can see the type of company that they were, from biotech to transportation logistics. I'm not going to go through all of that. You will be getting these slide decks after the presentation. Next slide, please. So it looked at the top mental and emotional issues that are affecting United States workers. And you can see on the right, the graph here, that almost 43% of them said that what's happening is 43% are feeling sad, and followed by angry, followed by lonely, followed by anxious to the point that they couldn't work, and then stressed to the point they couldn't work, and then almost 19% are feeling hopeless. 62% of the respondents were worried about their future or their family's future. Next slide, please. And they also looked at mental health issues and making it difficult to work. And you can see here on this slide that luckily about 36% or closer to 35% felt like their mental health issues were not interfering with their work. But almost 41% felt like they were somewhat making it difficult to work. And 40% have felt or come close to feeling completely burned out. Next slide, please. So while many are impacted by the issues that are happening right now in terms of mental health, not very many are receiving treatment, which is not very uncommon. I think we know that people typically don't seek mental health care. And you can see here that of those responding to this survey, only 14% are receiving treatment. And I don't know this for sure, but I would suggest maybe that this is even higher than what people are normally doing relative to employees receiving mental health treatment. One of the things I thought was really interesting, and you can see here on the left, that respondents under the age of 35 were 1.7 times more likely to have sought care. I'm personally excited about that. I'm hoping that the younger generation are really understanding mental health, that perhaps we're overcoming the stigma that's tied to mental health that I think keeps people from seeking mental health and substance use treatment. Next slide, please. On this slide, they looked at employees that are in significant distress, and 11% actually reported thinking about harming themselves or others. And on the right here, you see that 12% of people registering for care with Lyra Health reported thoughts of self-harm or suicide, which was a 33% increase since January, which is really pretty high. We do know that there's been an increase in suicidality since the pandemic, but we also know that suicide has been trending upward in our country for some time now. And in Kansas, that's definitely true, and we are seeing increases every year in Sedgwick County. Next slide, please. So the survey also looked at how folks are feeling about their employer support. You can see that not all companies provide the same level of support, but interestingly, 47% said that their employers have not communicated any message of support related to either the pandemic, social injustice, or anything relative to those issues. 40% didn't believe that their employer cares about their mental health, but really only about their ability to perform and be productive. 38% report their stress levels are so high they're considering a career change. And employees who don't feel supported are 2 times more likely to consider a career change. Now, obviously, with the economic downturn, people probably are less likely to seek a career change right now, which makes things even worse, because if you're unhappy, you have mental health issues, you're stressed, and you feel like you are burned out and have no way out, it's only going to make things even worse in the area of mental health and stress. Next slide, please. So we know that mental health is already a crisis, and it's something we've been focusing on at the Kansas Business Group on Health. And again, the National Alliance has been focusing on that. We're going to continue focusing on that. But during this time, we know that the crisis has really been exacerbated. And I'm not going to go over these very specifically. We're going to hear about telebehavioral health today, which I'm really excited about the increase in that. But we also know that we need to be doing more screening and testing for mental health and substance use disorders, kind of like we're focusing on COVID-19 testing. We also want to begin focusing, and we will be doing that in our Path Forward project I mentioned earlier. One of the focus areas of this project is the integration of behavioral health and primary care, or you can call it integrated care or collaborative care. Next slide, please. We know, however, that access still remains an issue, access to mental health care, and in working with our employer members, we hear that from them. They know that their employees are having difficulty having access to care. And while 95% of primary care clinicians join plan networks, only about half of mental health and substance use disorder specialists are in commercial networks. And the reason for that really is reimbursement issues. And a study by Milliman really did a deep dive into the disparity between healthcare reimbursement and mental health substance use disorder reimbursement, and there were really significant differences in that. And some of the activities that have been tried to improve network access really lack a systematic approach to that. So next slide, please. Some of the ways, specific ways that employers, you could offer more support to your employees is, first of all, break the silence on mental health. It's okay to talk about mental health. We need to be talking about this for so many different reasons, many of which I just talked about with regard to this survey. Communicate openly and often. Encourage your managers to check in with their team, and hopefully your managers know their staff well enough that they would be able to notice signs of distress. And so when they're finding that they're having issues, employees are having distress, connect them to some care. And I also just wanted to say one other thing quickly before we move to Dr. Leach. I listened to a webinar last week on compassion, and it was related to mental health and to how we can support our employees in the workplace. And the psychologist that presented that is her whole focus. And I think she is a professor at USC, but she's done a lot of research and written books on compassion. And compassion can go a long, long way, as we know, in our personal lives and our relationships, but obviously also in the workplace. So with that, I am going to now introduce Dr. Christy Leach. Before I do that, I also want to encourage you to, as you have questions that come up, please put them in your chat box. We won't get them till the end of Dr. Leach's presentation, but I encourage you to go ahead as they come up to put those in the chat box. So Dr. Christy Leach is originally from South Dakota. She completed her medical school and residency at the University of South Dakota. After several years of practice, she later completed her geriatric psychiatry fellowship at the University of South Florida, and she also had fellowship she was a faculty at the Bird Alzheimer's Research Institute. She's been in telehealth practice in Kansas since 2018, and I also heard her just say she is an aspiring writer. So thank you, Dr. Leach, so much for being with us today, and I'm looking forward to your presentation. And with that, I'm going to turn it over to you.
Well, thank you so much, Shelley. And so Shelley and Dr. Moore were so kind to ask me to speak with you all about my experiences in telehealth. You can advance the next slide. As she said, I have been working here in Kansas in the capacity as a telehealth psychiatrist for the VA Eastern Kansas healthcare system for the last couple of years. But even prior to that, in my work as a trailing spouse to my husband in the VA system, I've been doing telehealth, for about even 10 years. So telehealth has obviously been getting a lot more attention of late, but it's been around. And just to give you kind of a little bit of background with the work that I do, is that even though I work for the system that is based in Topeka and Leavenworth, I don't see any patients there. I see patients that are in St. Joseph, Missouri, in Lawrence, Kansas, in the area surrounding Kansas City, in Poplar Bluff, Missouri. I've never physically been to any of those locations. I've never physically been to Topeka and Leavenworth, VA. All of my hiring process, my credentialing process, all of that took place virtually. The only part that I had to kind of physically show up was to get my equipment issued to me, get my physical examination, and that was done at a local VA here in Wichita that sort of stepped in and did that as a favor to the remote VA location. But that's one of the strengths that telehealth has, is that so much of it can be done at a distance. And even with that, with my telehealth department, I am the local doctor being here in Wichita, but other doctors within my department are located in Kentucky and located in New York State. So we can be anywhere serving patients. Next slide, please. And so kind of getting to that, as Shelley mentioned, she mentioned Tele-Mental health. I'm talking about telehealth. What is all of that? E-health, telepsychiatry, teletherapy, telemedicine. All of these are really interchangeable, largely interchangeable terms for really delivering health care using an interface like we're using here. It means that the use of a technology is delivering care for a provider and a patient who are at a distance from one another. That can be in different parts of, it could honestly be in different parts of a hospital, from a clinic to a hospital, from one state to another, from one city to another, from one part of the country to another, from one part of the world to another. But it's just using a technological interface. And that type of interface can be one like we're using today. And the technical term that we use for it in medicine is a synchronous. just meaning that while I'm speaking with, moment to moment, you can hear me and see me moment to moment. And that is in the opposite of that would be asynchronous communication, or store and forward. And we'll talk a little bit more about that later. So next slide, please. And so as far as, today, I was asked to focus kind of more on telehealth services that are delivered for delivering mental health services. And so while we mostly think about kind of psychiatrists delivering that, it's also not just psychiatrists. And I hope most of you know, but just as a refresher, psychiatrists are a subspecialty of medicine. They're physicians, but we're also joined by psychologists. We're joined by licensed clinical social workers, those folks generally delivering therapy, but also doing assessments. RNs and other nursing staff can be a part of that clinical telehealth team. And so can physical therapy, occupational therapy, and recreation therapy. Next slide, please. And so when it comes to those type of services, within my scope within the VA, obviously it's going to be a little bit limited just by the patients that we serve within the VA. I see adults, I see geriatric patients, but outside of that system, of course, I have colleagues that are seeing children and adolescents. Part of my work is addictions and substance use. Different colleagues of mine are also doing what's called consultation and liaison psychiatry, of where patients that are hospitalized that may not, their primary reason for being in the hospital is not a mental health reason, but mental health issues are coming to the fore. That's where a psychiatrist might be brought in a remote type setting. Emergency services are sometimes provided remotely. And psychology services, either by a PhD psychologist, a licensed clinical social worker, different types of counseling, are seeing folks one-on-one. They're seeing folks as couples. They're seeing families with children. And they're also delivering group therapies. Next slide, please. And then telehealth nursing is helping patients with their medications. They're using remote technology to gather vitals, doing post-hospitalization follow-up. Social work is a really vital piece, often with folks on usually the ends of the age spectrum, with children, with geriatrics, of doing assessments and interventions, and the same with physical therapy and occupational therapy, especially with helping folks to stay in the home with doing those assessments and interventions. Next slide, please. And so, like I said, it's folks across the age spectrum that that telehealth and telemental health is serving. And it's serving couples, it's serving families, and it's also serving groups of people. Within my service, within the VA, groups have been a hugely integral part for patients' care. And when COVID came along, and initially those all got brought to a screeching halt, our PTSD groups, our anger management groups, our depression groups. But now, thanks to telehealth, those groups are kind of just like this one today, that we are able to serve patients remotely. And those also include like educational groups of patients newly diagnosed with diabetes and the challenges treating that, or sleep apnea. So those groups are able to continue and to be delivered remotely. Those groups may not also just include, like I said, the patients, but also include families and caregivers. So patients diagnosed with dementia, patients diagnosed with PTSD, caregiver education is a big part of what we do, and that can be delivered through telehealth. Next slide, please. And so traditionally, what a lot of folks think of when they think of telehealth is they think of a doctor communicating with a patient. And that's a large part of what my day is. But another part of what my day is also communicating with family, is that my visits often include family members. But a smaller part of my day too is communicating directly provider to provider. A family doctor in a clinic might have a clinical question regarding a patient and can bring me directly right into their office and discuss something. If there is a patient of mine or soon to be mine that is going to be discharging from an inpatient unit, I can be brought in part of that discharge conference and discuss it. If one of my patients needs to be handed off to a different provider because they're going to be moving or they're going to be transferring to a different level of care, I can accomplish that through telehealth. You know, even though I'm not there in the clinic, I am right there in the clinic on the wall. Next slide, please. And so the logistics of telehealth is one of its great strengths, but it's also one of its biggest challenges because of all of the different places that you can be with telehealth. Is that even though I am here in my home office, is I can be virtually anywhere. For the most part, prior to COVID, I was seeing patients in community-based outpatient clinics. Patients would come to their appointments that were scheduled in a clinic, and that appointment, so it's essentially that patient would have two appointments. They would have one appointment made in the clinic, and they'd have a second appointment made kind of in my office. Because even though I'm seeing that patient in the clinic, I could also potentially be seeing patients remotely at home, or sometimes they have a separate telephone clinic. And so to keep my various schedules straight is really just kind of quite a logistical headache for my schedulers, because those appointments are being made from like I said, from various different locations, and I could be moving from clinic to clinic. And like I said, that has its challenges, but it also has its strengths. Now with the advent of COVID, one of the things that we've been able to do is, after I see a patient in the clinic, we try to switch my clinic so that I now see a patient at their home utilizing their equipment. That gives the clinic time to clean and sanitize the room. It keeps our waiting rooms half full, and allows them the time to do the things that they need to do. And like I said, in other settings, patients could be seen in a hospital. One of the biggest utilizations that we're seeing now in telehealth, specifically in psychiatry, is utilizing psychiatrists in an emergency room. The wait time to see a psychiatrist in an outpatient setting, like on average across the country, is something like about 3 months. So patients who are, what I would say, not quite in crisis, but they're in it. They're having difficulties. They need help, but they're not necessarily suicidal. They're not homicidal. They're not psychotic. They're not the things that we would normally deem a psychiatric emergency, but they need help and they need it urgently. They present to an emergency room, and they are now, in this day and age, they're exposing themselves to COVID. They're taking up an emergency bed, and in an emergency room, they are occupying that bed on average for about, I think it's something along an order of about 12 hours, waiting for a psychiatrist to see them, evaluate them, and clear them for discharge. Whereas now with telehealth services, a psychiatrist can see them remotely, get them in and out of an ER on average in about 4 hours. And so that's really been a huge game changer in a lot of areas that are underserved, that don't have access to psychiatric services in person. So that's been a big change. And one of the other areas that we're now seeing patients, now that they can be seen, quote unquote, anywhere, is trying to see patients who are working. And that's really presented a lot of challenges. And even seeing patients at home honestly presents challenges. Because as we've seen with news broadcasters trying to deliver us the news from home, is that finding a place of privacy, finding a place that's quiet, that somebody can conduct a private medical appointment, is difficult under even the best of circumstances. I was just conferring with my colleagues about our foibles in this area, of oftentimes getting patients to understand that these type of visits, can't be conducted in a bathroom stall at the office. They can't be conducted in a stairwell. They can't be conducted, just in a cubicle in an otherwise open area, because privacy can't be assured. They can't be conducted in a car at the drive-thru at McDonald's, or in the checkout lane at the hardware store. These are all areas that patients have attempted to conduct their doctor's visits with us. And then at home, it's very normal and natural for folks to lower their inhibitions. You're at home after all. But to make people understand that people need to be fully dressed for their appointments, that folks need to not engage in using alcohol or using drugs while they're having their visit with a doctor, is important, and just one of the normal expectations. But kind of more common things is just where to draw the line about having children present, spouses present. And I think what Shelley said before, though, too, is having compassion, is that everyone is really struggling with this pandemic. And so we just have to have a little bit of grace for our patients, and also sometimes even grace for ourselves. My cats have frequently interrupted some of my appointments, and sometimes I've had interruptions with deliveries or telephone calls during my appointments. And so they've extended me that grace as well. And then I just kind of have a little reminder here on this slide. I'm lucky enough to be in the same time zone as where I serve my patients. My colleagues are not so lucky. So that's one of the other considerations that we have to consider when doing telehealth, is that sometimes patients and providers are in vastly different time zones. And sometimes patients, providers, and schedulers are all in different time zones. So that's one of the other considerations, is that, when making appointments, that everyone needs to be crystal clear about when and where everybody is. Next slide, please. And so, like I said, I've been talking about having these type of appointments. The equipment that I'm using for my visits was all issued by my employer. When patients see me in a clinic, that equipment is dedicated, standalone, only for telehealth equipment. That's all it can be used for. It can't be sort of sidelined and used for something else, which is really handy. Because as we know, sometimes in an office, if you show up sometimes and it's like, oh no, that's being used right now, we're going to have to shove you into some other room or whatnot, that can be quite an issue with limited resources. So that's really important to know if you're looking at a different platform, if it requires standalone dedicated equipment. And we see that more kind of in a clinic or hospital setting, whereas in a home setting, it might be something that, it's perfectly all right to use a patient's tablet, smartphone, or PC. And then it kind of goes into, well, what are the requirements for that technology? Is this something where a cellular line is going to be enough, or is this something where Wi-Fi is going to be required? And in an estate like Kansas, that high-speed internet availability is one of our biggest rate limiting steps with providing telehealth to patients. Is even if we can get them a tablet, if they don't have access to Wi-Fi, it's really a moot point, because we can't get them that service reliably. Even some of my patients, one of my patients, he doesn't have a landline, he only has a cell phone, and his cell phone only works on like one hill on his farm. So I know that when I was calling him for his appointments, if he didn't pick up right away, I just had to wait 5 minutes and, you know, give him a chance to walk up that hill. So it's just, we just have to be cognizant of these unique challenges that, that our patients are being presented with, you know, in utilizing this technology. And we're seeing these kind of same sort of struggles that people have had with, you know, utilizing distance learning. And also of just also being cognizant too of that, when everybody switched over to trying to do these virtual visits back in March and April, you know, at the same time, this is when kids went home and started trying to do distance learning. This is at the same time that people started trying to work from home. People got laid off and were using Hulu and Netflix like nobody's business. It was, the system got pushed to its limits, and a lot of times we couldn't even do some of our visits because there just was not enough bandwidth on the system. And those are things to really kind of really need to start, you know, keeping in mind. Next slide, please. And so another thing to think about is in delivering that care, how much telehealth is the care, who is delivering that care, and how much telehealth are they doing? In my service, there's no way to see me in person. I am 100% telehealth all of the time. People can't see me face to face, even if they wanted to. There's just no process in place to do that. But I think that for the most part, that's exceedingly rare. The majority of providers that have been jumping into telehealth are in traditional practice, and because of the needs of the pandemic, they are now moving into either a blended or a hybrid model where, in addition to their face-to-face visits, they are offering now telehealth services. And I don't think one is any better than the other. It's just, I think, important to know for patients that if they want to have that option of having somebody that they can see face-to-face, it's important to know if that's a possibility. And that's one of the things that, you know, that I discuss with patients, or have discussed with patients when they're getting set up to see me, is that they know that this is 100% telehealth, because there's just some patients that, you know, want to have somebody that they can breathe the same air with. So it's important that people know up front what they're getting, that it's not, that you don't want to kind of pull the rug out from somebody that they assume, oh, I'm going to see this person in telehealth to start, later I can see them face to face. You don't want to set people up for disappointment like that. Next slide, please. And so, like I said, it is a lot of providers sort of jumping right into telehealth right now. And it's a bit like the wild, wild west out there, because these are folks that don't necessarily have that much experience with it, because it is like, as we're delivering this presentation to you all today, this is not the same as if I was in the room there with you. Delivering this talk in the same room in front of folks, you know, it's a different energy, it's a different vibe. People would feel free to, maybe somebody would have a question, or there'd be giggles at some point, or there'd be reactions that I could react to. This is very different, or there'd be conversations that people would have before and after. And it's the same way when you're delivering care face to face. It is a different animal delivering care through telehealth, and psychiatry and psychology, mental health adds a whole different layer of complexity of learning to develop that therapeutic rapport with a patient when you never breathe the same air, when you don't ever get to shake hands, you don't ever get to touch a shoulder, you don't ever get to lean in and really touch that patient. It's a different skill set, and it takes time to learn. That took me time to realize myself. And I think that physicians, though, understand that. I found it really interesting when I read the results of the survey about comfort with telehealth, and patients are more comfortable with the idea of telehealth than physicians are. And so that was actually quite heartening to me, that I think that physicians realize they realize the limitations of this. They realize that it is a different skill set. And so I think that gave me a little bit of hope, that I think that people have sort of jumped in, and I think that they are kind of swimming back to the edge of the pool to kind of say, is this really the best fit for me and my patients? Next slide, please. And so, this has all been kind of brought about by, by COVID. Telehealth existed before this, it's going to exist after this, but the changes that have brought about this, that have been brought about by COVID, have been, I can't even describe, but I'll try to a little bit. Next slide, please. So the law that made these changes possible was the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, that they passed back in March. And it really brought down 3 big barriers that have really kept telehealth sort of on the fringes. And those barriers really they weren't really barriers for the VA. And that's really why the VA has been on the forefront of delivering telehealth. With VA care, getting patients the care that they need, worrying about reimbursement has never been an issue. Worrying about licensure of, am I licensed in the same state that my patient is located in? Never been an issue because of the federal licensure issues within VA. So it's not been so much an issue for me, but in the civilian side of things, these were major issues, and those barriers just tumbled. The biggest thing that they did with the CARES Act was brought parity to reimbursement of telehealth visit to face-to-face care. And this recognizes that telehealth care is equal to the quality, that they are the same. And this was recently in the New York Times to show how big of a change this brought about, was that Medicare reimbursed $60 million of telehealth services in March and April of last year. March and April of this year, they reimbursed $4 billion of services, which is, I promised I wasn't going to use the word unprecedented, but that's just unprecedented. I mean, that type of increase, that order of magnitude, I don't think has been seen. If that's going to continue, I don't know that it is, but the other piece of that has to do with location of services. One of the other big barriers in place was where services could be delivered. And telehealth to home was one of the services that they didn't want to pay for. And now that's included. And so that's been a big game changer. Next slide, please. Two other regulations that have been temporarily suspended were regulations around controlled substances and HIPAA protections. The Ryan Haidt Online Pharmacy Consumer Protection Act, this was passed back in 2008. And really this law was put into place to pretty much prevent the development of online pill mills. And what this required was that in order for a telehealth provider to prescribe a controlled substance to a patient, is they first had to have a face-to-face meeting. Within VA, this wasn't an issue. What they said was that if a patient was seen in a clinic through telehealth, that met the measure, and it didn't apply. But the Ryan Haidt Act has really put the tamp down on a lot of telehealth platforms because once patients found out that they couldn't receive any controlled substances through telehealth, that ended their interest in it. And then when it came to HIPAA protections, it's not like they said, oh, you could just blab your mouth about anything that a patient tells you. What they said was that the requirements regarding communication with patients weren't as strict. So for instance, we're using Zoom to conduct this visit or this meeting. And they said that, hey, if you need to, you can use Zoom. There's a separate product that you have to pay for called, I think it's called Zoom for Medical, that has like end-to-end encryption. But that's a barrier for some practices. And so they said that you could use things like Zoom, you could use FaceTime, you could use Skype. And so that was one of the last barriers to come down. And so now that those barriers have come down, they are down for the duration of the pandemic, the COVID-19 emergency. And so there's now sort of some push to keep these down. I'm going to leave that to our legislatures and politicians and whatnot to kind of see what all comes of that. But these are kind of this was the law, and these were the regulations that came down that opened the floodgates. And so that's kind of what I had today. Last slide there. I'm ready for your questions now.
Well, thank you so much, Dr. Leach. And Matt, I don't know if you're getting anything on that, but now is the time to ask questions. I actually have some myself.
I'll try my best.
Okay. Gosh. Well, one thing I wondered about was, have you noticed, or maybe, I don't know, basically, have you noticed more patients needing telemental health or telepsychiatry since COVID? And I mean, maybe you can only see so many a day, so maybe that is kind of a dumb question, but I mean, have any kind of thoughts on that, whether you're actually seeing more people, or people are requesting more?
Well, what I would say is that like with my patient base, I see an older population base. Mm-hmm. And initially what had happened was when the outbreak started, all of my patient visits were canceled and they were transferred to telephone visits. Oh. And now we're slowly transferring those to a combination, like I said, of clinic visits and video to home visits. And what I'm doing with my patients is, like your survey had kind of borne out, is that everybody is weathering the storm a little bit differently. And so I'm offering patients the option, if they feel like they need, even if they're telling me they're doing well, I offer them the option of a little bit more frequent follow-up during this period of time. And I would say about 1/3 take me up on it. And so it's, the vast majority of people are doing well. There's a lot more just generalized anxiety. I think one article called it plague dread. People 55 and older are really, are struggling with just kind of the day-to-day anxiety about it. But I'm not seeing a lot more just kind of new consults of just like new people, new introductions within my clinic space. But some of that is just within VA, our demand is just kind of so high at baseline. It's a little bit hard to see some of those fluctuations because some of that too is going to be outstripped by like the needs of the military and changes with like discharges from, we're located to several Army bases, and so influxes and changes with staffing there has more of an impact on us.
Okay, all right.
And I think, let me see there's some, the chat box.
There's 2 more questions there.
So
Yeah,
yes, are there any special procedures needed to handle psychiatric emergencies via telemedicine versus in person? So yeah, so generally if there's every facility that we work at, we have drawn out procedures for the handling of for emergencies. And those are managed by what's called our telecommunications technician. Is that these are our boots in the ground. These are our eyes, ears, nose, and hands in the clinic. And so if somebody has an emergency, a psychiatric emergency or a medical emergency there in the clinic, we have communication procedures and then backup communication procedures to coordinate with the local staff to get that patient to that higher level of care. And generally what that involves is generally it first begins with just getting another person in the room with them. Because sometimes when somebody is in a crisis, is that it really is difficult to maintain that therapeutic alliance through the screen. And they do better if we can get somebody face-to-face in the room there with them. It's a different procedure if we're doing a video visit to home. And so one of the first things that we have to establish when we're doing video visits is somebody's actual location. The majority of the time people are doing their visit at home, but like I said, somebody can be at work, somebody could be in their car in a parking lot somewhere. So the first thing that we have to do when we're doing those type of visits is establish their physical location in case we have to alert emergency services. And we use a special electronic emergency 911 service, because one of the, if right now, if you dial 911 from your phone, it pings to the nearest cell tower and it goes to your county. And it's a county-based system. And that will do you zero good if you're trying to get 911 services to somebody that's in a different state. It's really, really tricky. So we use this different outside service to get those emergency services when needed. And that's where it's just, if you're looking at a service, that would definitely be a question that I'd ask, like how they handle emergencies, how they do that coordination. Because it's just, thankfully, it's not something we use very often, but it's kind of like your ALS service, your BLS training, thankfully you don't use it very often, but you need to, refresh it and know what those procedures are in place.
Okay.
And then let's see, could you talk more about the clinical differences about seeing patients in person versus telemedicine? So what I would say is that the biggest difference in the quality of care between seeing a patient through telemedicine, through seeing in person, the biggest difference is going to be there. And this is what I've seen personally, and this is what the research bears out. And it has to do with patient preference. A patient who wants to be seen in telehealth is going to have a good telehealth experience. A patient who does not want to be seen in telehealth is not going to have a good telehealth experience. So that is what's going to be the biggest rate limiting step there, is patient agreement. And so the areas where that can come to the fore is that, when it comes to seeing patients have to give informed consent. They have to agree to be seen. And so when I see a patient in the clinic, generally, sometimes there's this assumption, well, they're in the office, of course they want to be seen. They're there to see you, they made an appointment. But as we know, like in reality, sometimes that isn't the case. Sometimes they were pressured to make that appointment. Sometimes they just got a card in the mail and they forgot what it was for and they just sort of show up. And sometimes patients agree to telehealth without really fully understanding what that is. And so when they come to the office and they see a face on the screen, they they back up and they really don't want that. And so we always give patients the option of not being seen or giving it a try. When I have patients who initially come into the visit and they did not remember or understand that it was telehealth, and I explained to them that of course they don't have to be seen. Of course we can switch them over to see an in-person provider as soon as possible, maybe not that same day, but within 30 days. But they also have the option of seeing me. I don't bite, I can't bite, I'm on the screen. I would say greater than 75% of the time after they complete a visit, they decide to stay with telehealth because they realize that you can have a connection. You can form a therapeutic alliance with somebody through a TV screen. Another part where it can become a little bit tricky is in emergency settings, is that if you have patients, like I said, who present to an emergency room, not quite in a crisis, but it's urgent, they want to be seen. They don't know if they really want to be seen by a person in the TV, but when they're presented with the option of like, look, it's this, or waiting 12 hours to be seen by a person, that can sometimes be a little bit, coercive, but, but it's also reality of there may not be another option, or it may mean not being seen that day at all. Or sometimes if a person is in a crisis, it can mean being evaluated and potentially being discharged, or if somebody doesn't feel safe discharging them without a psychiatrist's input, being involuntary committed to a hospital. So those can be some kind of trickier things to navigate. I can't speak as much to that because I don't provide that type of service. Areas where it can be a little bit tricky, even when a patient does agree to telehealth initially, are patients that have mild to moderate cognitive impairment, difficulties with reality testing due to psychosis. And so patients that are experiencing some psychotic symptoms due to bipolar disorder or schizophrenia that have a difficult time with distinguishing reality. So, one of the questions that we ask when we're looking for psychosis is, do you hear messages that are intended for you? Do people in the TV talk to you? So sometimes for individuals that are struggling with understanding, the edges of reality versus their own imagination, a woman in the TV talking to them can be incredibly confusing, that they do not understand that is a person remotely talking to them, that is a real person, that is not a TV image, that's a means of communication. And sometimes people, it's just, they cannot wrap their heads around it, or it's too much mental effort to both stay in reality and continue a conversation. So those folks aren't appropriate for telehealth. And sometimes folks that have a certain degree of cognitive impairment that's moderate because of that, and same reason, can't quite wrap their heads around what's going on, or can't understand why their wife is talking to the TV and not talking to them. Those folks, it might be too difficult for them to understand what's going on. So that sometimes presents a unique challenge. Then on the flip side, people with much more mild cognitive impairment or much more severe cognitive impairment, where the main communication is through a caregiver, telehealth can be very appropriate and helpful in those circumstances. And so
I think we have one last question.
And that question about the challenges of getting acceptance and reimbursement, that I can't speak to because of my work in the VA. I thankfully don't have to worry about the reimbursement side of things. But when I have spoken to some of my colleagues on the civilian side, that it's going very well, that they're finding it much easier. And a lot of them are, instead of doing kind of piecemeal, they're working through employers, they're kind of working through insurance. Most of them are working directly through insurance. Insurance companies are hiring them rather than individual patients.
Mm-hmm. Okay. Well, that is actually going to be, I think, a nice segue into maybe a bit of what Dr. Sweeten's going to talk about. But I'm going to go ahead and thank you so much, Dr. Leach, for being with us today and helping us understand telehealth and telebehavioral health. So I really appreciate your time and thank you so much.
It's my pleasure. Thank you so much for having me.
You bet. Okay, I am now going to introduce Dr. Jennifer Sweeten. Dr. Sweeten was originally trained as a neuroscientist. She is a clinical and forensic psychologist, best-selling author, and internationally recognized expert on trauma, anxiety, and the neuroscience of mental health. She's the author of the book Trauma Treatment Toolbox, published by PESI Publishing and Media. Dr. Sweeten completed her doctoral training at Stanford University School of Medicine, the Pacific Graduate School of Psychology, and the National Center for PTSD. Additionally, she holds a master's degree in affective neuroscience from Stanford University and studied behavioral genetics at Harvard University. Wow. Dr. Sweeten resides in the greater Kansas City area where she owns a group private practice, Kansas City Mental Health Associates, and co-owns MindWorks Professional Education, Inc., a continuing education company. And I will say that's actually how I learned about Dr. Sweeten. I attended one of her trainings and it was really, really good. And so I reached out to her and appreciate so much your willingness to do this today, Dr. Sweeten. So with that, I'm going to go ahead and turn it over to you.
Okay, awesome. Thank you, Shelley. Well, good morning, everyone. Happy to be here to talk a little bit about telemental health during COVID. So there's been a lot of great information already shared. I'll do my best not to overlap too much, but give some additional information and also leave time for questions. I think we have, I'm just doing a time check here, maybe until about 11:30. Okay, so maybe I'll chat a little bit for like 20 minutes and then definitely let me know what questions you have. I want to make this as valuable as I possibly can. So as Shelley was mentioning, I'm a licensed clinical psychologist. My specialty is trauma and PTSD. I also work with some anxiety disorders. In my, I guess you could say, my former life, before I went into private practice, I actually began my career as a VA psychologist. So it was kind of fun to hear from a VA psychiatrist. And I was actually a telemental health psychologist in the VA system before jumping ship into private practice. And since that time, I've been about 50-50, pre-pandemic, about 50-50 in terms of tele versus in-person therapy. During the pandemic, I've been 100% teletherapy. And now, you know, we're in this kind of weird in between. It's going to last who knows how long. But I'm about 10 to 15% in person and the rest tele, with the understanding that it could go back to 100% tele at any time. So I primarily see my patients in Kansas, some in Missouri, Oklahoma, a few other states here and there. It just kind of depending on what the licensing laws are and the regulations. And I see folks in Australia and Singapore right now too. So a slight time difference. So I'm definitely well acquainted with how therapy goes, kind of what the limitations can be, what the advantages are, and I can share some of that with you. Okay, so telemental health in COVID. Okay, so I know Shelley showed you some pretty graphs and stats. I'll probably just elaborate a little bit on what you might be seeing in your employees or with your family members or friends. So I always put a lot of words on slides. It doesn't mean that we need to talk about every word, but some of the main things to be aware of. Okay, everything that I'm about to say is probably going to worsen with time. I put that at the very bottom of the slide. So that's one thing to keep in mind, is that we are still really early in this whole thing. We don't even know people who have had COVID and are trying to recover. We don't even know the long-term medical effects. We're not even like 6 months out. And the thing about mental health conditions is that, you know, sometimes they surface pretty early in situations like this, but they could also surface months or years down the line. So the best way that you can think about this, and if that kind of guides you in terms of what you might expect, think about this as kind of a combination between people's predisposition toward mental illness, like the genetic factors that might lead someone to being vulnerable to mental illness, combined with environmental factors. So in psychology, we have this kind of this fancy term called the diathesis stress model. And basically what it means is that everybody is born with some sort of genetic predisposition to mental illness of some sort, whether that predisposition is really low or whether it's really high. Okay, so we all have some sort of predisposition, and then life happens, and then things happen, and then something like this pandemic where it affects everyone. I mean, this is actually pretty cataclysmic. It's affecting everyone. This is a huge environmental stressor that's come into play all of a sudden, in addition to people's other environmental stressors, and in addition to the stuff that's happening as a result of the pandemic. Okay, kids being at home from school, spouses being laid off, right? All the other stuff that comes. So we all start off with some sort of genetic predisposition for mental illness, and then life happens. And the diathesis stress model says you have this genetic predisposition, and then as the more that the life happens stuff happens, right? The more that it increases your chances of getting sick. So we all have some tipping point. Maybe the tipping point is here. Okay? If your genetic vulnerability is here, then you have a lot of life stuff that can happen before you tip over the edge and get sick with something. For those individuals who are right up here, okay, they have a lot of genetic loading. It's not going to take much to throw them over. So what you might be seeing is employees who are right up here, right? A lot of genetic loading. They might be getting sick with this pandemic, mentally ill, I mean, within a few weeks, right? Not much is going to tip them over. But the longer this goes on, the longer the uncertainty, the longer the anxiety and this kind of collective societal anxiety that we're going through, the more it increases. And so what we're going to probably be seeing is people getting sick with a variety of different mental health conditions, but the main ones being depression and anxiety. But this is going to be happening for a very, very, very long time, as long as this is really going on. The main things you're going to see, depression and anxiety. I put depression at the top. This is going to be a main thing. And this is going to be fairly straightforward in terms of what's causing it, because we know that if you want to make somebody depressed, even who has no genetic predisposition for depression, if you want to make them depressed, then you trap them at home and you take away their social supports and they can't go do anything and they can't see people, and that's really a great recipe for depression. This is also why people will retire and then they retire and die, a few years later if they're not retiring to something and they're retiring away from life. Okay, so we kind of see that. So depression is going to happen when behavioral activation goes down. And behavioral activation is just a term for doing stuff, being out into the world, seeing people, being busy, going to work, going to school. You take away behavioral activation and you're going to get a lot of people who are going to get depressed. And I'm already seeing this in my practice, and the other clinicians I consult with are definitely seeing major increase in depression. The other thing that you're going to be seeing is anxiety increasing. Okay, and this is a little bit, this actually can be a little bit trickier. So it's probably no surprise to you that anxiety is going to go up when there's uncertainty and there's danger. Okay, so that kind of makes sense. So there's this illness out there. Okay, we're in the middle of this pandemic and we don't know how big it's going to get, and we don't know if it's going to touch us personally or to what extent. When we get sick, we don't know what's going to happen to us, and we don't know what the long-term effects are because we're not 5 years, 10 years out to really see. We don't have a vaccine. So this is a recipe for anxiety. But the tricky piece about the anxiety is that, okay, you have that straightforward piece, right? Which is the uncertainty and the scary, kind of the scariness of all of it. But the insidious piece or the anxiety is that it's not going to fully surface until things can open up even more. And I'm starting to see this with my clients as things have opened some. Okay, so anxiety is hitting now, but it's going to hit a lot harder, I would say, probably after the vaccine. Okay, and I know that doesn't seem to make any sense on the surface, but the reason why, this is primarily going to be for people with a history of anxiety. It's because with anxiety, a main way that people cope maladaptively with anxiety is they avoid stuff. Okay? A hallmark of anxiety is avoidance. Okay, so for instance, if you have social anxiety and you're not getting treatment, what you probably do is you avoid. You don't go out. You don't see people, right? You're not calling people. You're not, maybe you're not giving presentations on a big stage. I know everything I do now is like this, right? It's very, very different. And so those individuals with social anxiety, with phobias, okay, with driving anxiety or a driving phobia, people with a lot of times generalized anxiety, they're able to hunker down and stay inside, which actually, even though the virus is really scary, makes them feel safer. But as we know, anxiety treatment is made to pull you out. Okay, so I'm thinking about clients that I have with driving phobias. This is really hard right now to get them in the car and to drive because they don't have to. In fact, they're being told they should stay home. So it's hard for me to get them in the car, driving, going nowhere. But when they have to drop their kids off at school, then it changes, right? So what I'm saying is that these anxieties that are present in a lot of people are going to stay dormant as long as they're staying in. But the second everything opens back up, you're going to see a dramatic spike. And again, I've already seen this in my practice as things have opened some. And it's going to be an anxiety that is much, much worse than it was pre-pandemic. Because what we know about anxiety is that the more you avoid the thing that you're afraid of, the stronger the anxiety becomes. So now I'm working with these clients who used to be in person and now they're tele, where the anxiety about something like driving or going to the grocery store is absolutely debilitating. And now they have agoraphobia. Agoraphobia is just a fear of leaving your house. So we're going to see a massive spike in agoraphobia and these other anxiety disorders. So that just to say that, yeah, the pandemic is hard. There's a lot of anxiety and depression that's happening right now, but expect this to actually get a whole lot worse in the future. Okay. The other thing I put up on the slide, I'm a trauma psychologist, so to mention something about PTSD, post-traumatic stress disorder. I've seen this kind of go both ways in my practice during the pandemic, but a lot of times symptoms are worsening because people are not as active and they're alone with their own thoughts and they're not sometimes as busy. Now, some people are more busy. They have kids at home or something like that. But some of my clients find that now they feel trapped in their own head. Okay, so and that doesn't always feel good when you have PTSD. So you might see PTSD increasing. I think even later you're going to see even more anxiety, and we definitely see depression increasing. The bottom of the slide, I mentioned suicides, and I say suicides may rise. We know for sure at least youth suicides are already way up. Okay, it's still early to get a lot of this data, but so far it does look like suicides are on the rise. And I really attribute that to the depression piece more than anything else. Okay, so our mental health is definitely suffering right now, and I think it's going to continue to get worse. The other thing I'll mention is substance use. I know, I think this was mentioned before, substance use is increasing across the board with individuals who do struggle with problematic use and for people who don't. It's increasing. And so if the person has that predisposition to problematic drinking, for instance, they're much more likely to be having problems right now. Also keep in mind, domestic violence is up. I didn't put this on the slide. Child abuse is up, but actually child abuse reporting is down because who tends to report child abuse is the school. Okay, but the data are still indicating though that the abuse is going up, but the reporting of it is going down, which is pretty scary. Okay, other things to keep in mind. Right now, people are very much in survival mode. And when we go into survival mode, there's a lot of energy that goes behind that. And it causes this short-term nervous system dysregulation where everything goes into high alert in your body and your brain. Okay, so back in March when nobody could find toilet paper, hey, this is the result of that survival mode. And psychologists kind of joke about how symbolic it is or kind of Freudian it is that everybody's considered or super concerned about their bowel movements and just how Freudian that is. But that speaks to the survival that we're all concerned about. We want food. We want to make sure our bowel movements are taken care of. It's like these very basic things that we revert back to. And that's fine for short term, right? For the short term. But now we're like 5 months in. And what we're seeing is that people are getting more revved up. and getting exhausted from being revved up, or they're starting to collapse a little bit. And that's where you see people maybe being a little bit less vigilant or taking risks that don't make a lot of logical sense. So when you put people into an ongoing survival mode, like we've been in now for months on end, what you're going to see is the nervous system dysregulating and eventually either turning on, and that's going to look like anxiety, okay? Chronic anxiety and anxiety disorders. For some folks, it's going to turn off, and that can begin to look like depression and lower energy, apathy, not caring. People are getting physically worn down by this, and they're getting mentally and emotionally worn down by this. So that's really what we're looking at. Of course, along with this is a lot of times this feeling that there's nothing we can do about it, or there's some things we can do, but it's limited. Hopelessness, helplessness. I talk to any parent right now with school-age children, and they'll tell you that there's just no solution that feels great right now. There's no solution that has no downsides. So this is really difficult. It really does bring on those feelings of like helplessness, like I can't do the right thing in this situation. And the ongoing feelings of just being disconnected. That's something to keep in mind. If you have employees that are usually working in an office with each other, and now they don't have that. Maybe that's good for some people. I know a lot of people like working from home, but you get less social connection. And if it were the case that they were working from home, but we weren't in a pandemic and they were getting all of this social connectivity outside of work, maybe it wouldn't be a big deal. But we know that people are increasingly isolated. So they're not maybe getting access to human beings outside of their home. Okay, so people are getting disconnected from coworkers. There's a lot of digital communication right now happening, maybe a lot of messaging, a lot of emailing, a lot of texting, where it's harder to read tone. Emotions really aren't captured as well, and it can actually lead to higher conflicts, more conflict, more misunderstandings, more alienation. So these are all some things just to consider that are probably playing a role in people's mental health statuses during COVID. Okay, signs of mental illness. And I'm thinking about this from an employer perspective. So things that you're going to watch out for. Of course, the difficulty with this is that you're not maybe face-to-face with people as much. So you may not be seen as much. Some of these things may fly under the radar a little bit, but things to watch out for. A big thing is taking more sick days. Okay, that we know that is a major outcome, especially of depression, clinical depression. So taking more sick days. If you notice that someone is socially withdrawing or getting into more conflicts. Okay, so the social withdrawal thing is kind of like the nervous system shutting down. That's going to look like depression. They're going to pull back. Getting into more conflicts, that's going to be more nervous system getting stuck in the on position, more anxiety-based or trauma-based, and people are going to be a little more at each other's throats potentially. So kind of looking at the behavioral changes, also personality changes. If you're looking at somebody's performance or the way that they're interacting with you and it just doesn't seem like they're themselves, consider that there could be something mental health-wise happening. Making more mistakes, getting less done. Of course, that can also happen when people are at home, and if you have 4 kids running around and cats crawling all over your computers and you can't get a moment to yourself, there could be other justifications, I guess, for these things. But people might be making more mistakes because their brain isn't functioning in the way it normally does. Maybe the logical areas of their brain are getting shut down by the fear center of their brain, which is sending alarm bells all the time because we're in the middle of this social crisis. People seem disinterested. People seem distracted at work, right? That could also be kind of the nervous system turning off or on edge and nervous all the time. Again, nervous system turned more on. Sometimes employees will even talk about mental health stuff. Kind of depends on what industry you're in and what the workplace culture tends to be. So listening for that too. But these are just things to watch out for. You may also hear from some employees about other employees. So somebody might come to you and say, hey, I'm worried about Bob. He seems to be a little bit off. I notice that he's not getting his reports in on time. So maybe you don't see it directly, but you're hearing about it from other employees that might be close to one another. Okay, so watching out for those. In terms of then getting care, we definitely want folks to get care, to get mental health treatment. Now of all times, it's really, really important. What's going to hold people back from getting the care that they need? First of all, it's going to be stigma or lack of support. Okay, if they think that, you only go to therapy when you're ready to jump off a bridge because it must mean that you are nuts. That's the kind of stigma that gets us into trouble. So people don't get help until they are very, 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 very sick, as opposed to getting help when they're feeling a little bit off so that things can be changed before it gets too bad. Okay, but stigma will hold people back. So I think it's important to have workplaces that promote mental health, promote prevention of mental illness, open discussions about it, I think can be really helpful. Keeping in mind cost. Cost can absolutely be a barrier. Now, with more telemental health and some insurance companies shifting, we are seeing much better reimbursement right now for telemental health services than in the past, which is great. We're hoping that that continues. But otherwise, cost can be a real barrier for folks. And I know different companies, different businesses might be able to help in different ways, depending what the resources look like. Getting time off work, that can be a major barrier as well. Not even knowing if help is available. Sometimes people just don't even know what's possible. They don't realize maybe that telemental health is an option. Sometimes they have to be told, hey, even though we're in the middle of a pandemic, there's still care that you can receive that is excellent care. And I'll say here in a few minutes a little bit more about how telemental health is actually a great way to do therapy. Fears around confidentiality that can sometimes go with the stigma. Can be kind of just a lack of understanding of how therapy works and that therapy is confidential. And of course, transportation issues or internet issues. So I think telemental health is great because you don't have the transportation issues, but having done nothing but tele for the past 5 or so months, or almost nothing but tele, I can tell you, internet issues can be a real thing. People think they have a strong connection and they don't, or they are desperate to get away from their family and their kids. So they're like in their closet or in their garage, or they're out back in the garden. Not ideal necessarily, but it's the only way they can maybe get that space and time to themselves. And sometimes the internet issues can become problematic. So there are going to be some challenges around that. But these are the things that are going to stop your employees from getting help. So kind of keeping that in the back of your mind, and then thinking about, from your perspective, is there anything you can do in your position as an employer to try to mitigate some of these barriers and address some of these. In terms of therapy during COVID, I could talk all day about this. I actually have been doing presentations for other clinicians about how you do therapy during COVID, calibrating or recalibrating your expectations and how to help this go as smoothly as possible. Maybe some things that would be relevant for you to know as employers is in-person therapy is not going to be possible during a lot of this. Okay. Again, maybe only 10% right now. My caseload is in person, and that's after a lengthy piece of paper is signed that was crafted by an attorney with like a million different rules about coming into the office. A lot of clinicians aren't even offering that though, even 10% of their caseload. They're going totally virtual, especially later career clinicians where if they're over the age of 50, if they're living with people who have chronic medical conditions. Just know that getting that in-person work may become increasingly difficult. And a lot of therapists, depending on where they are geographically, but a lot of therapists are permanently moving sessions online forever and ever. One of those people being my own mother, actually. So she's in her 60s, she's later career. She's a lot of clients per week. She's actually giving up her office space. She's decided she's done with in-person forever. Clinicians in New York City made this determination like 4 months ago. They were all giving up their offices forever. So know that therapy online is the future. I'm not going to say you can't get an in-person therapist, but it's going to become increasingly difficult, probably until there's, a vaccine. But honestly, even then, because the overhead is so much lower when you do it online, there's going to be a lot of clinicians who get established online, get their office set up at home, and they'll never ever go back. Okay, so I'm a big proponent of online therapy because I really think this is where we're going. And if you talk to the young people, college age, the college students, the early 20s, they for the most part actually do prefer to do it like this because this is kind of how they live a lot of their life anyway. Okay, other things about therapy during COVID. Insurance companies, this depends on the state, this depends on the insurance company itself, but more insurance companies are reimbursing for telemental health, which is fantastic. And just keep in mind that when we're thinking about tele versus in-person, and there's a lot of studies comparing the two. Keep in mind that sometimes the comparison, especially if you're in the middle of a pandemic, the comparison isn't so much, is tele better than in person, but rather is tele better than nothing at all? Because that's really the option that a lot of us are facing right now. And the answer overwhelmingly is tele is better than nothing at all. And I would actually argue, according to the research, tele is comparable to in person. So long as, and we just heard this, so long as people are open to it. So the best predictor about whether or not it's going to work is whether the client is on board. But in my trainings with clinicians, I talk a lot about what clinicians can do to exude confidence and tell clients about telemental health in a way that makes them a little bit more comfortable with it. So if a clinician is kind of scared of it, is like, oh, I don't know about this, the clients are not going to follow them into telemental health. So there's a lot that we can do as clinicians to provide some psychoeducation and that confidence that yeah, teletherapy can work really well for a lot of people. Okay, I'm just going to do a quick time check. I'm going to stop here in a second for questions, but upsides of telemental health, increased access to care. I mean, this is huge. Again, the comparison is tele to nothing, not just tele to in person. Huge increased access to care. No transportation is needed. You can do it while you're in the comfort of your own home. Less time away from work and family. Okay, this is really important. If you had to drive 30 minutes to see your therapist and then 30 minutes back and your therapist can only see you on the lunch hour, well, that's at least 2 hours off work. You can't do that. But with telemental health, you can. Okay? The transportation piece gets totally taken out. It's also great for inclement weather. You don't have to get on icy roads. We don't have to deal with, last minute cancellations as much. Reduce overhead for therapists, reduce childcare for a lot of the clients that I see. Of course, you don't probably want your kids listening in on your sessions. So it's important to be able to have a private space, but sometimes it's the case that if they go check on their 9-year-old every 15 minutes and they put me on hold, then that can be okay. And they can actually still have a fairly uninterrupted session without having to worry about what's happening to their children. Main things though, upsides of telemental health, human connection. This is so important during a pandemic, that human connection is still possible and therapy usually works just as well. We know this about multiple evidence-based therapies for PTSD, such as prolonged exposure, which is a really intense therapy, such as cognitive processing therapy. Increasingly, we know that EMDR also works. I won't get into all those therapies, but know that a lot of the therapies that we go to are therapies that work. The main therapies that are not going to work so well during a pandemic are going to be the anxiety-based ones where it's behavioral, where we're telling them, I want you to, go spend 45 minutes in Walmart because you have agoraphobia and you're scared to leave your house. Obviously, we can't be doing that work during the pandemic. But really, for a lot of the other stuff that we treat, therapy works just as well like this as it does in person. I'm including here some slides kind of at the back with a whole bunch of research, a whole bunch of references. I came from a research background, so I can't resist. When I put up my last slide before the references, you'll see my email. If you want these slides, you can have these slides and you can see the research references at the back if you ever want to check anything out. But really with the telemental health, especially during the pandemic, the human connection piece is critical. This is just a slide talking about why we need to stay connected. So if you don't stay connected, you get depressed. If you don't stay connected, you're more likely to develop PTSD after a traumatic event. Okay? You're more likely actually to experience anxiety because you don't feel that sense of cohesion and you don't get soothed by other human beings. So main reason why I tell clinicians stay connected to your clients, even if they are on their ATV out back, even if they're in the garden or they're hiding in the closet from their kids. Yeah, this is not ideal for therapy, but right now they're getting nothing. So it's really important that we make this connection and they feel the social support with their therapist. Long and the short of it is when you stay connected to supportive social systems, it helps you with a whole bunch of stuff. You can see a whole bunch of stuff here. Okay, reduces stress, reduces anxiety, reduces blood pressure, improves sleep, improves depression, reduces cortisol. Okay, cortisol is that stress hormone. When you get social support from someone, cortisol gets cranked down as oxytocin gets cranked up. So what you get is less stress and more of a feeling of connectedness with other people. And keeping in mind that the therapist's relationship with that client might be one of the remaining connections in the person's life during a time like this. If you want these slides and you want to check out this TED Talk, this is a TED Talk basically talking about how social connectedness is really important. And when you get that social support, you crank up the knob on oxytocin, which makes you feel calmer. And when you do that, you actually crank down the knob on the stress hormone cortisol. Okay, so one of the conclusions from this TED Talk is that your biological stress response is nudging you to tell someone how you feel, meaning to connect with other human beings instead of bottling it up. And that's a main issue that we're facing with the pandemic right now, is that people are having to bottle a lot up. Okay, so I want to be mindful of the time. Start taking questions here. I put a slide in here about the cost of not getting help. Basically, it's expensive. It's really, really, really expensive. You can check out this slide. You can even do the depression calculator to see how much it might be costing your company if people have untreated mental health issues. Okay, but it's really expensive. Things you can do, watch out for the signs. So that other slide that I gave about signs of mental illness. Try to enforce work hours if hours can be flexible so that folks can attend mental health appointments. That's great. Staying in contact with employees, trying to get face-to-face so you can read nonverbals, kind of get a temperature read on how people are doing. Reasonable accommodations whenever it's possible, and encouraging employees to whatever extent it feels appropriate to do so to be healthy, to get up from the desk, to go on a walk with the dogs. You know, behavioral activation, exercise, engagement with other employees are all things that we can be doing right now to try to get through this period in the best way that we can. Okay, I'm gonna go ahead and stop here. On these other slides, you're gonna see like some nerdy, citations, but I wanna stop here and answer any questions that might be on your mind about COVID, telemental health. I know a lot of questions have already been answered, but anything else that's on your mind? I'm gonna see here if I can get to the chat box.
Yeah, there's one, if you can see it.
Yeah, I can see it.
Okay.
It says, what is your experience with Kansas private insurers on reimbursement? Okay, so my experience is only what I've been seeing, honestly, in the local Facebook groups with other therapists, and it looks like a lot of the main insurances are doing pretty good, like Blue Cross Blue Shield and United, from what I'm hearing. Now, I am private pay, so I'm an all cash business, so I can't say from personal experience, but from what I'm seeing, these I guess deadlines keep getting extended, where basically telehealth is getting reimbursed more and more. So I think it's getting better, but I know that that's kind of a vague answer.
Thank you. Thank you. Well, I actually have some questions, and
Sure.
That was great. I mean, I couldn't agree with you more. And the whole thing about social isolation, I have to tell you, my youngest son, who's 26, has been out of our house for a while, and he came over last night, and he was so like needing to talk to someone that basically 2 hours that he talked to me, because he just, felt like he really didn't have anybody else that he could talk to. So that's just so important what you were saying. A couple of questions that I have, Dr. Sweeten. What platform do you use for your telehealth?
Oh, great question. I use DoxyMe. Okay, so I'm going to put it in the chat if you want to ever go see it. Doxy. It's DOXY.ME. It is a HIPAA compliant, encrypted, confidential telemedicine platform. It is free unless you are like a company, like a private practice. It's like a group practice, and then you have to pay. But otherwise, it is free. You sign a BAA, which basically means that if something goes wrong with the technology, confidential information gets out there, the legal responsibility falls on DoxyMe and not you as the clinician. So I use DoxyMe. Sometimes I also use the telemedicine add-on for Theranost. I'm putting this in the chat as well. Theranost. Okay, so I use both of those, just kind of depending on client preference.
Okay, great. And then I had a question about family therapy or group therapy, and I don't know if you do that. If you do, then this question would be you could probably answer it. But does that work as well for when you have more than one person? So if you're doing group therapy or if you're doing a family therapy kind of situation?
Yeah, so it's an empirical question in terms of what are the outcomes, and I don't know about that. In terms of the feasibility, yeah, it's going to look kind of Brady Bunch style, like on Zoom, how you have that, like that view. But yeah, like in DoxyMe, you can. I've heard of therapists doing, co-parenting sessions where one parent is in a different state, now depending on the state's guidelines, of course, but one parent can be in one state, another parent can be in another state, and the kid can be in a different room, and they can all be together. So logistically, yeah, it's absolutely possible. I know there are people who do group therapy. I personally don't. I do a little bit of couples therapy, but that, and then individual. But yeah, people are out there doing it.
Yeah, okay. And then another question I have is, okay, aside from age, because I think we, understand that younger people seem to be more receptive to it, but are there any other characteristics that you have found in people that seem to be more receptive to telemental health?
That is a really good question. I have not myself, just anecdotally, I have not noticed. I will tell you, everybody switched over on my caseload, except for 2 people who were doing pretty good anyway. Otherwise, everyone switched over. But it was kind of interesting. When all this happened, I had a couple of people that I was supervising at the time, which have now graduated. But one of these supervisees was really wanting to do online therapy, was really excited about it. The other one was really tentative and was like, I really don't feel comfortable with this. And it was interesting that about 80% of the clients of the clinician who was really excited about it transferred, but only one on the other one ever did. So with the other supervisee, only one of her clients ever was even willing to try mental health. So I'm saying that to say, I think a lot of it has to do with how we present it, because I've been doing telehealth therapy for my whole career, basically. I think I'm able to present it in a way that makes people comfortable. We do like a test run. I go over things about confidentiality and security. We even talk about, VPNs, if we want to make it look like the IP address is located in a different place. I mean, anything that their concern is, I can usually address. So I think a lot of it really has to do with clinician attitudes. Otherwise, I've not noticed anything really with clients, but keep in mind too, I work primarily with trauma and anxiety. So I'm probably missing, a lot of other populations.
Okay. I had one other question, and it's kind of a dumb one, but does anybody else have any questions? If you do, please put them in the chat box here real quickly, because I know we're over time, but that's because I made us over time. But the question I have is, and I guess maybe back to what you had spoken about in terms of anxiety, but I'm just curious if you have noticed at all, and maybe it's not even related to your practice, but that it seems like I am seeing people kind of get to the end of their rope. And so my question is more in terms of like expression of anger, external expressions of that, and increased conflict. Have you noticed that more lately with everything that's going on? And like I said, that may be kind of a dumb question, but I'm just
Yeah.
kind of curious about that.
Yes. Yeah. I think the answer is yes. I mean, this is just anecdotal. I don't have any data on that. But yeah, and what I've attributed it to with my own caseload is that you're not around very many people, and the people you're around all the time. So if there's, in a marriage, if there's any pre-existing tensions or issues, which everybody has, right? There's no marriage that doesn't have those. So I think that just gets amped up. So yeah, I am hearing a lot more about that. I'm seeing more of that. In the couples therapy I do, people aren't doing as well. But there can be some strengths with that as well, where people are reconnecting after not having been very connected. So it can kind of go either way. But yeah, I think when you get some depression, you get some anxiety, you get the same people that you're around all the time and nobody else, it's kind of a recipe for increased conflict.
Okay. Yeah, I agree. Well, I think those are all the questions. I don't see any more. And so I just want to thank you so much for the presentation. It was really great and a lot of great information. I appreciate your time and really interesting. So thank you so much for that.
Absolutely. Thank you for having me.
You bet. Okay, and we're going to wrap up here real quickly. I do want to let you all know that there will be a document sent to you after the presentation that will have a list of additional resources on there, local resources for the Wichita community, as well as virtual mental health resources. You'll be getting that document after. I also want to remind you that we are having our monthly HR forum on August the 25th. For those of you that are in HR, this is just an opportunity to meet with other local HR professionals. And right now we're talking still about COVID, and it's just a chance to share things that are working, things that aren't working, issues that have come up, and it's just a real interactive, informal opportunity. We have a health literacy tentatively trained or scheduled for October. That is being sponsored by Merck, and they don't have virtual training. Apparently they're not able to do that. So I'm kind of thinking that's probably not going to happen because it was scheduled for in person. So it's still on the books, but like I say, I'm giving it maybe a 10% chance of actually continuing in person. And then also, if you're a member of the Business Group on Health, we will begin having biannual all-member meetings. And we're looking at early October for our first meeting. We're close to having a date for that, and you'll be notified of that very soon. And also, if you're not a member of the Business Group on Health, certainly we'd love to talk with you about membership. With that, I'm going to close. Remind you to wash your hands, social distance, wear your mask, and have a great Tuesday. Thank you.